We're in a real state of flux as a profession. There's a lot of things changing and a lot of people talking about a lot of issues. The leaders in our profession talk about this all the time, and we're trying to find solutions, but we often don't get to hear from the frontline pharmacists. So today was an opportunity to hear from the people who are out on the front lines and to have them tell us what they need so that we can really focus our energies, not only in continuing education, which is the side I'm speaking from, but also the associations and the regulatory bodies and the employers, so that they can help focus their efforts on doing the things that the frontline people will need.
For us as an association, we know that nothing's going to happen unless every pharmacist in this province is committed to making that happen. And this was an opportunity for us to get a large group of people into a room to talk about all of the barriers, to talk about the opportunities, and to really prioritize what our role is as an advocacy organization in helping to move this change forward.
I just wanted to quote Linda Strand, who's the guru in pharmaceutical care, and she talks about pharmacy practice as not being the place that you work in, so it's not the building. Our practice is not dispensing. Our practice is actually being accountable to patients for optimal drug therapy, and that includes doing a patient assessment, a care plan, and monitoring and follow-up. I think we all know that a lot of things are changing in our practice. We're hearing all kinds of things about changing legislation, expanding scope of practice, technician regulation, new pharmacy services, changing compensation models.
So this is coming. And if what the focus I'd like to get you to is are these questions. What do you need in this new environment to practice to full scope? And there's perhaps a matter of urgency here. What do you need to get to full scope faster? We don't want to just hear from a few people. We want to hear every voice that's in this room about what it is that you need. And we want to give you the opportunity to focus on what is most important to you. The process that we're going to use is something called open space. And what open space is, and this will really scare the organized freaks here, is it is a meeting without an agenda. But you are going to create the agenda based on what's most important to you. Working in this environment, yes, there's ambiguity. What is it that's burning in you in terms of a question about how to move forward?
The concerns that I have as a practicing pharmacist is the time that we have to do things.
How do I fit into a collaborative care practice within a community setting?
Patients' medical charts, and when will retail pharmacists have access to them?
I want to be a part of this change, but I want also to know, where do I start?
We want to know, how do we get support from physicians, and how are they informed of our expanded scope of practice?
I'd like to talk about some examples in our history, in our own experience, where we've had to manage change on this scale and we've been successful.
As a professional, how do I own my profession and not stalker a building?
What immediate tools are needed to support these roles?
Is this something that the public wants?
How does or how will the regulated pharmacy technician support pharmacy practice and pharmacists?
What are the things that you can give up or move to someone else?
If all barriers were removed, would you practice with medication management as your foundation of practice?
All of the pharmacists said they were interested in all sorts of new services. So that actually wasn't the issue. So another group is going to have to deal with the barriers, or the why aren't we either doing some of the opportunities that exist today, and what some of the barriers are going to be moving forward. We certainly separated them into two categories: drug or prescription processing focused, so adapting a prescription therapeutic substitution, and, 3 sections. A second section were services that were all built around MTM, or medication therapy management. We acknowledged that we were yelling out different services, that basically everything we do could be centered around a patient assessment, creating a care plan, and creating some sort of follow-up plan, and that when we're looking at reimbursement, we should actually advise those speaking to payers and other stakeholders involved in that discussion that we should be trying to attach reimbursement to those 3 pieces.
It has to come from the individual pharmacist. It's up to us to push this forward, that we can no longer rely on advocacy associations, the regulatory association, and visualized by the registrar, or corporations. And just a secondary one to that is for pharmacists and employers. Pharmacists in particular, we needed to gain confidence in what it is that we do and have an open-mindedness. And we were very proactive in thinking that we wanted our corporations to have that open-mindedness as well.
You'll be happy to know that we concluded that change is possible, even for us. There's a quote that I'm thinking of, and probably somebody here knows it off by heart. It might be your email trailer. I think it's Margaret Mead, about never doubt that change in the world can be affected by a small group of dedicated people. In fact, that's the only way it's ever happened. So I guess that was that kind of encapsulates what we the aha moment that we had.
We could see a role for a pharmacy technician, a regulated pharmacy technician, accountable to their own practice, to allow the pharmacists the time to free them up from those technical aspects to focus more on patient-directed services. There was certainly a recognition that how is this going to come together in practice? Big concern about the business model, and we are dealing with community practice and businesses, and how is that all going to unfold. So, we didn't come up with any answers on that. Obviously, it's a big key piece. We've got things moving in tandem here with regulation of technicians and expanded scope of practice, and also looking at the business model for pharmacies. So, it's yet to be worked out. We came to, I think, an agreement that it would be good for employers and pharmacists to understand what the role of the regulated technician would be, so to start thinking about that and how that might play in each individual setting. I always encourage, certainly, technicians, pharmacists, and employers to start having those discussions in their own workplace, and getting ready and getting prepared for that, and anticipating that change to come.
Our table felt that time management and the legal concerns of our practice now are very important, because presently, before the technicians become legally responsible for drug distribution, that is our legal responsibility as well as upholding the various standards that are being put forth by a professional society. This is, in the next while, I think will be a challenge to try and fulfill everything that we should be doing. And I feel that until that technical role is in place, it will be very difficult with the present. I mean, we all have financial restraints as far as staffing and this type of thing go. And in addition, the documentation that we're being asked to perform as well for, certainly most of the documentation we decided we were doing in the past, but perhaps the standardization of documentation would be worthwhile looking at as well.
We have to recognize that we can't do it all. We have to choose our role and what is most important to us. We also need to redefine our role as a pharmacist, so what we thought we would do when we graduated versus what is expected of us to do now. One of the things that we also talked about was, if our role a few years ago was just dispensing, well, that role is now going to the licensed technicians. So that's one of the things that we have to get used to and embrace. And then we also said that not only is it important for us to be a leader, but it's also important for us to be the follower because we need to support one another in these initiatives, and we need to start by getting involved. So whether it be contacting, the PANs or contacting the board and just volunteering your time.
The biggest insight is that we didn't want to lose what we already do. So the whole discussion was sort of around how do we fit medication management into what we already do? So can we do it in bits and pieces while we're doing our everyday work? And we thought we could. We thought we could, do our monitoring of therapy at every refill, and we could identify drug-related problems at any step along the way, what we already do. So it was very encouraging that we felt that we can do this without changing a whole lot, but what we do need is a really good documentation system so that we have a reliable patient chart that looks like the physician's patient chart, and we have all the information that we need, and it's just a continuous process that gets put into our day. How beautiful would that be?
One group was really particular that they would like interprofessional education. So all healthcare professionals doing education together, as well as some of them were even saying maybe some of these events could involve patients as well, so that we're really integrating the whole team together. And there was a lot of talk about technology and how to use that optimally for education, as well as educating people on some of the technology that's available. The other group had a really good focus on peer networking and having students in pharmacies, which I thought was really enlightening. It's really important to keep students in your pharmacy so that they ask questions and they keep more experienced pharmacists asking these new things, but then the more experienced pharmacists are able to share their experience with the students. So it was working as a network, and they thought that was really important. So I thought it was a really good session. Thank you.
Basically, we were trying to solve the age-old problem about how do we take this wonderful work that people have been doing over the last few years, implement it, and then stick with it when all the pressure is going to come from corporate to go after market share. So we had a large group, a very good group. I'm not sure we solved the problem, but we have a couple of recommendations. One of the strongest ones was that there needs to be a suggested fee guide, not corporate specific, come out from, I guess PANS would be the likely body that would do that covers everything from blister packing to the price for adapting prescriptions all the way through injections and medication reviews. So there's no guarantee that we would all stick with that, but at least that would be a good starting point. The question was asked, would you accept a lower rate of pay from a guy that's going to charge full price for a injection versus a higher rate of pay from someone who's going to charge $2 for injection services? And unfortunately, the answer was everyone, pretty much every time, would probably take the higher rate of pay because we're all worried about our job security. So, that's the reality. If we can find a way to solve that problem, then we may be able to find a way to solve the rest of these problems. We also talked about the need to get all the way early into their education, and as early as second year, the PEP program at DAL. If we can spend some time with the students in their clinical rotations, with the owners actually going through budgets and understanding how these stores make money, or in some cases don't make money, I think that might be valuable. So start them early so that when they make their choices along the way, they can be educated on that.
We're talking about physicians and how some, it seems the newer licensed physicians already have an idea through their education what pharmacists can do and embrace us a little bit, maybe not to the full extent that we'd like, but we all know in our practice we have reticent physicians who just don't care what we do and are very turf protective, territorial, and non-collaborative in their approach to us. And I guess the underlying theme that came out was that we sort of have to understand their point of view as well, and not just say you don't understand us, and realizing that pharmacists do share some of the blame in that we don't collaborate with physicians very well. There are some barriers to that, and our time constraints do play a big part in that. So it's kind of like the key theme that came through ours is like, stop saying you can't persuade physicians. Just try to persuade a physician. One physician, a little bit at a time. Do something that you can do.
Okay, so the basis of my group's discussion was predicated on the fact that if the public has a service that they feel enhances their health, or if there is a service that improves their accessibility to healthcare, even if there is a cost to it, then if they value it, if they believe in it, and if they're willing to go to the government to lobby for it, then our world can change a lot. Our group had made comments that the fact is, because of our frequent contact with the public and that we see patients so many times throughout the year, we have an enormous opportunity. And I think our group really recognized that opportunity, but the fact is we didn't make that a focal point of our interactions. In fact, some ways we actually hid the fact that we were providing value to our service. The comment was made in our group that sometimes if we identify a drug interaction, we will call the doctor without ever telling the patient what we were doing. In some ways just to try to protect the patient, but then also hiding the fact from the patient that we provide an enormously valuable service. Essentially, our biggest insight is that we can do a lot, but we have to be more conscientious about the fact of what we are doing. We already have good relationships that we've built with the patients, and what we do is we have to shape their perception and shape our work environment so that they see us as the clinicians that we are. So in terms of pharmacists, our role is to educate the public, lead by example, not hiding behind what we do, and working together with our employers so that we get the support and tools we need so that we can help each other adjust the context of our service so that we can enhance the perception of pharmacists and the value of pharmacy as a clinician. So really about building better relationships so that people can really appreciate what it is we offer and that they feel it in a way that they're willing to go to their MLA.
The answer was, in the current business model, not a lot. That people are pretty busy, that there are maybe a few smaller things, but not enough that would amount to a significant amount of free time. So then we started to talk about, well, in a perfect world, what would you do? If resources and time weren't an issue, what would the role of the pharmacist look like? What would the role of a pharmacy technician look like? And I think overwhelmingly it's what we've been hearing is pharmacists want to practice to their full scope. They want to do more. They want more one-on-one. They want to do that in-depth counseling. They want to do the medication reviews. They want, I think the word that was used over and over in our group is they want to do what they're passionate about. They want to go to work and they want to love what they do every day, and they're more than willing to pass off those other duties to other people. There was a lot of concern over the structural environment that most pharmacists work in now. Most pharmacists are employees, and they work in an employer's environment, so that they can't maybe make all those changes without the help of their employers, so they need their employers. But the one thing that was reiterated is that they do have a role. They have to. I think one of the individuals at the group said, my frontline pharmacist came to me and said, I want to do this. Let's find a way to do that and let's figure that out. So even though you may feel perhaps limited in scope, it does. It just takes a conversation to get things rolling, and that we do all have that role.
The first one is communication. Once that fee schedule or that reimbursement model is in place, then we need to do a really good job of communicating to our members internally and to the public and to other healthcare providers so that it's an ongoing two-way communication from the regulatory bodies, from PANS, whoever is involved, down through to the practitioners and to the public, and also feeding back up so that it's constantly evolving and improving. The second part, to be really effective in the role that consistently came through in all of our discussions, was the access to medical information. Of course, within our scope of practice and what's provided for us by our standards and regulations, specifically topics related to patient assessment tools, and to make it practical and workable, to have some sort of software or documentation process for making this quick and easy so that it's doable and it has to be practical.
The first suggestion was we'd implement whatever's paid for first. And so med reviews paid for now, and people were prepared to do that. Although I'm going to allude back to my other group, which said we really need 2 levels of med review, and they would like to see the program restructured. And what we really need is to be able to explain what the value of our services is. We need to put a value on every service that we do, whether it's being charged for or not, and we all have to sing from the same song sheet and say this is what it's worth, whether you're charging that or not, or whether the patient's paying or the government's paying or whatever. The prescribing, the whole prescribing services and emergency prescribing, we felt like we could do that really easily because it's kind of what we already do. You know, prescribing for minor ailments, we already do that, so that's going to be a quick, easy thing to implement into practice right now. And the third thing, we're offering programs like smoking cessation and things because they are measurable outcomes and services that you can get statistics for to go back to government to say X number of patients quit smoking because of us.
Our biggest insight was pharmacy is not a commodity, it is a profession with inherent individual professional responsibilities for each pharmacist, and the only way to own the profession is to be involved. And we kind of segued a bit from that into it's important to regain credibility versus marketing as a profession. And examples of that is fee cutting for our service, air miles, all those types of incentives for people to change. It was felt too many people working the front line are cut off from the fiscal understanding of their particular business, that they didn't understand where their paycheck came from, so they didn't understand the impact that maybe, I mean, I'm really pro expanded professional scope, but what impact does that have on the bottom line, and how are all of us, ourselves as professional pharmacists and our employers, going to deal with that? And then it came down to, where is the frontline pharmacist's power? Where is their voice? Who speaks for us? And that's a really, really interesting question that I challenge you all to think about.
I was really impressed with the fact that pharmacists were willing to change. I can see motivation in the room that they're wanting to embrace it, and as long as they have what they need to move forward, that they're willing to do that. So I don't think there's as many motivational barriers as maybe we anticipate. And I think that pharmacists are hard workers, and that they're willing to make the steps that we need to make to go to the next level, which was really encouraging to hear.